Good afternoon, everyone, and thank you so much for the invitation to be here. It's my first meeting, and everyone has been super welcoming. I had many times I was standing alone, and people came up to me, which is a fantastic experience, especially when you're used to going to conferences where you're probably the only female, but there are so many female company here. So I am a physician, I'm an interventional radiologist, but I also spent some time maintaining an open source project for radiology, which kind of makes sense because I'm a radiologist first. And I'm just going to give you a story about sort of my life up to where and how I got into doing health IT. So this is a picture of the medical records room in Malawi. I spent some time there 2 years ago. And so I'll take sort of an approach of where it's more of a storytelling approach, which is going to be very different. So I hope you'll take something from this. And so I went to medical school in Kenya, and that's actually the inpatient service for our hospital. And it's a 6-year program. And every time, you wait for the 4th year because you finally have your stethoscope, you can wear your lab coat, you march in, and the end really looks like close, like, okay, I'm gonna be a doctor, and it's fantastic. It's a great feeling. And this was me, going in, I'm like, yeah, I'm a 4th year, nodding. And this was actually in 2007. And so, but the reality for me ended up being this. It was chaotic. And because one thing was happening around that time, we had a big HIV patient population. Most of the countries in Africa had not declared HIV as a pandemic. And so in the inpatient units, you'd go back to the, the ends of the, the wards, we call them the wards, and there'd be these patients who you didn't know what to do with them. And it's a phenomenon how that changed by the time I was done with medical school and, a very big sort of outlook. And so, there were people who were already in Kenya, and this guy, Joe Mamlin, is a phenomenon human being. He was nominated for a Nobel Prize a few years ago, and he had retired from Indiana University and had gone to Africa with his wife. And, seeing sort of how it was going to be so difficult taking care of the HIV patients, and he brought this thing that, that really I take as a mantra as a physician, which is leading with care. And, and this was saying, before we do research, and this is a common thing about global health, before we do research, we get famous, we really have to provide, standard care, good quality care for the patients we serve. And to do that, it required for us to be able to know who was getting treated, who died, who was coming back, who needed a little more help with food. And so the very first sort of form of digital record was actually based on, Excel and Access. Actually, it's a little of an oxymoron to be saying that on Microsoft's campus, but there was a limit in terms of how many number of records you could have in the database. And so, and I want to go back to that element of leading with care. Sharing with one of my friends whom we've worked in global health with, and, they were supervising a PhD student from Botswana, actually Namibia last year. And, this student got these databases. You're wondering what medical records are there in Namibia. And, they got these two, databases, and mainly it's Excel somewhere. And they merged them together to show that one of the ARV medications, which was shown to cause anemia early, only causes anemia for a short time, and it's self-limiting. And you can imagine that's something like, okay, so what does that mean? It means a country doesn't have to order more expensive medication, and you can sort of plan and change the outcome and the workflows for taking care of HIV patients. Those type of questions and that sort of freedom is what represents global health for me, but it's impossible without some of the building blocks around health IT. And so, There are three physicians here, and the guy on the right there is actually Bach Mamling, who's Joe's son. And, they were attending EMEA. Some of you attend EMEA. And, they were chatting like, oh, this is what we are experiencing in Africa. What are you experiencing? And, they started scribbling one of the earliest data models for an open source medical record system. This system, when it was first implemented, was when I was doing my clinical work. And right now it is in over 3,000 sites, called OpenMRS, serving 8.6 million patients. And so, that's the glamour, that's the good side. And unfortunately, fortunately and unfortunately, we have lots of ownership. So you can look at the left side, the present time. All those are various flavors of OpenMRS. Countries take it up, say, I'm going to implement this, and this is what is good for our local setting. But, this will be a familiar picture to most of us. We start having many applications. And we know we struggled with this, at least in the US, because it's very difficult, and that's why we are all here, interoperability. And I think it's good that we have new apps, because I don't think one size fits all, but it's dangerous because I think we have an there's a chance that we may miss that opportunity to leapfrog and just go down the rabbit hole of these systems that do not really help us take care of patients and become a nightmare to maintain in a place where we already do not have enough resources. And so we actually did a study with some colleagues of mine where we looked at actually OpenMRS and looked at how the contributions had done. And, in global health, and you can think about with the HIV pandemic, the founders, those early physicians came together and said this is the right thing to do. And the founders recruit other people and they inspire people to solve problems. And you see, then you have this community that you can see the dotted line, the code contributions just peak, and because you're having a lot of input, and then they start to plateau. And that time, the amount of downloads and implementation sort of is steadily growing. And then everything starts to drop. And obviously, you get to a more mature product and you start to see the downloads sort of keep going up, but the contributions start to drop. And I think this, for me, is where I see FHIR as the glue that can help us sort of manage that phase 4 transition well. And so I'm going to give you 2 examples of projects that I've done. This track is not just a track. It has an Xray, and it goes to almost 60 centers in Western Kenya every week. And the reason for this is that it takes chest X-rays for patients who have HIV, and to help screen for tuberculosis, which is the biggest, the earliest killer of patients with a new HIV diagnosis. And we have an implementation of a very simple radiology interpretation tool. And you can see, because we all really know, at least implementing HL7 is very difficult, and it's even more difficult when you don't have a personnel. And you can see our results there. The results are just presented as CD4 counts, chest X-ray. It's not very consumable, especially to a healthcare physician, who's like, okay, was I looking at CD4 count? Was I looking at the infiltrate? What does this mean? And so we ended up, linking the ref packs. There's already a lab implementation of HL7, which, had taken many years to get up and going. There's sort of a little bit of a decision support system. And so there was already an authentication system, and so we just needed a way to plug in those 2 things to work together. And so this is the outcome where we sort of just present the results in a much better consumable way for people to use. And, you can compare, radiographs easily without, wondering whether you have a big PAC system and what's your viewer. And with this, we were only able to do with just 2 resources, the diagnostic report and imaging study, and some web. And the developer who worked on this with me had not heard of HL7, had never heard of FHIR before, had no imaging informatics skills, worked on this for 1 week, and actually got a better job and left. And we've not had to, that's good for him, but the project is still up. And so the big thing here for global health, it's okay, you don't have to implement the whole, FHIR server. One resource, focus on your problem, and I think it's okay. Some people may disagree, but I think it's okay. So going back, I'm going to show another different project. it's very difficult to train and also retain the developers. You know, it takes honestly around 2 years to get your developer up to speed. And, you know, you cannot afford to pay them well. So someone else is gonna, you know, pluck them out and go away with them. And that's good. You know, you want people to be successful and you want them to move on. And so, like I said, with these many apps, we start to get, I think, increasingly far removed from patient outcomes. And we're also starting to take care of more complex patients, you know. Now, when I was growing up, the life expectancy in Kenya was 55 years, and now it's, you know, higher than that. So that comes with more diseases. And like the US, where it's more like you have to get paid, the reporting burden is to funders, and it gets higher and higher because, I mean, the money pool is not limitless. And so what we've started to do is, we thought, what would be sort of a platform that helps people still have the freedom to focus on their global health problems? And one, we said, there's a big burden of data reporting. You have many organizations you're reporting to, and this can take a lot of time. It affects flow of resources to you. And so we said we're gonna innovate on how to do better reporting. And then, you know, we said, it's easy to teach anyone to do HTML. If I can show you code, I can get you up and running in a week, and if you go, that's okay. Because you're empowered, but it's also easy for me to bring someone else. And so we started doing this thing where we call the web components. There's a really phenomenal talk actually at this meeting on web components. And you know, most of the devices, we don't have laptops, we use mobile devices. And so sort of adopting the Google Materials design helps us, you know, you can build once and rent on different devices more comfortably. And then that leaves many other problems like electricity and offline storage and sync and many other problems. But we felt like this would be the toolkit of the future, which we're actually working on. And so in this one, we moved to a Cassandra database. And actually, Sana has an open source product for which, you know, I mean, sort of linking your data from Apache Spark to to Cassandra, and then built an SQL query. And these are some of this was done by a student during the last year Google Sum of Code. You can see she built, this is a quick way to say, hey, show me all patients with more than 15 observations. And we also realized that not everyone will be able to write SQL codes. And this is just a quick way, you know, to provide a UI around FHIR resources that we can use. And this is an example of our web component. And we just literally want you to say, because we envision that we can teach you and say, hey, when you're building an EMR, this is your problem. What you need is to think about data. You need maybe some images, you need some patient stuff, and we can just teach you the tags that represent this. And sort of, because it, you know, when you're training about health informatics, which already has a high learning curve, and then you're training on the technical element. And we hope that by just sort of being very consistent with our message, that we can have a chance to improve the capacity. And so last year, we tried some components from a Google Sum of Code student. This year, we have another Google Sum of Code students. You see, we are starting to learn a few things, like in open source, like better ways of organizing our components so that it's more scalable and more people can work on this. And so I don't think any one solution honestly fits for every problem. I think we have, what I see FHIR for at least my work and my team's work is that it's an enabler, both technical and also freedom to problem solve. I think global health has always to go back to local solutions for local problems. And we have to rethink education, we have to rethink interoperability, and this idea of scaling to save lives. And actually, there's something else I really like, this idea of reverse innovation. For example, if your company is hiring and you don't have time to onboard someone, these open source projects are a fantastic way to get people involved. They still get to learn the same resources that you need, but it's still a win for us, and it's a win for you. So if you want to check out some of the stuff we're doing, that's what we're doing. And I'm always open to getting more feedback and a better way to do things. Thank you.